Now, coming to the preoperative planning, which is very, very important and crucial for the successful outcome of these lenses. These lenses, as we know, they are used to correct the myopia, hyperopia, astigmatism, and can be used in cases of stable keratoconus. Apart from this, off-labelly, we can use to correct the post-refractive surgery cases, post-cross-linked cases, post-keratoplasty, post-cataract surgery for correction of the residual refractive error as a piggyback lens, and pediatric anisometropia, and for the correction of presbyopia. The contraindications are the presence of any lens opacity, any pseudo-exfoliation, damage to the zonules, coloboma lens, zonulopathy, pigment dispersion, and if there is a progressive refractive error. Our corneal endothelial cell count should be more than 2,000 cells per cubic millimeter, and there should not be any pre-existing corneal endothelial dysfunction or dystrophy. And there should not be a glaucoma, especially angle closure glaucoma. It is contraindicated in grade 2, less than grade 2 angles. This is very important, measurement of the anterior chamber depth, we will be discussing shortly. And in pregnancy nursing, as we do it other refractive surgery procedures, any other ocular pathology like uveitis, corneal degeneration or dystrophy, macular pathology, neovascularization, all these cases where there is instability or some comorbidity or pathology, we should avoid this procedure. It is indicated in age group 21 and 45 years, but we do it in above 18 years of age when the refraction is stable. There is no change in refraction of more than 0.5 diopters in last 1 year. Especially it is done for LASIK rejects, but I have done in less than 2 diopters cases also, because their parents don't want to that their cornea should be not be damaged, and the procedure, because it is reversible, it is preferred over this, and the quality of vision definitely is superior. LASIK rejects come like patients of high myopia, when the cornea is thin, less than 500 micron, or in cases of dry eye, when the pupils are large, or in a very excessively flat or very, very steep cornea, or keratoconus suspect cases also. The lens should be clear, unsatisfactory vision with intolerance of contact lenses or spectacles, but nowadays we do it even when they don't want to, even these are there. Appropriate pupil size for the specified phakic IOL, and endothelial cell count, I have already said it should be more than 2,000. Adequate crystalline lens rise is also another aspect which we see now. No ocular pathology, as we have discussed earlier. The preoperative assessment, like in any refractive procedure, uncorrected, best corrected visual acuity, complete manifest and cycloplegic refraction should be done. Complete slit lamp examination for the cornea, lens, entire IOP measurement. There should not be glaucoma, angles should be open, corneal topography and keratometry is done. Fundus examination right up to the periphery in all cases is mandatory. Corneal horizontal white to white measurement, this is, and the AC depth measurement. These are special tools which should be done in all these cases. The internal ACD is important. Internal ACD is the measurement of the anterior chamber depth from the posterior surface of cornea up to the anterior surface of the lens. Topography and tomography is done in all these cases, which is mandatory. It gives us the steep or flat keratometry value with their respective axis. It helps us in ruling out progressive ectasias and suspects. It gives internal ACD and horizontal white-to-white measurement, which is imperative to surgical planning. And it rules out any ectasia or the keratoconus or the cases of keratoconus suspect, which we don't want to do, in which we don't want to go for the corneal refractive procedures. Coming to the horizontal white-to-white, this is what we have to measure, the limbus on either side, from nasal to the temporal side, and it is from measured in a horizontal meridian from 0 to 180 degree. And the simple and reliable way to measure is with the help of these calipers, which are easily available, but they should be verified by the measuring these calipers, because the markings are sometimes erroneous, so they should be checked with the ruler. And nowadays, we do it with a digital caliper, the bottom side, which are freely available and we are very cost effective. And it is sterilized. And apart from digital calipers, we can measure white to white by OBSCAN, Pentacam, IOL Master, UBM, wherein we measure sulcus to sulcus, Vernal caliper, and some other advanced autorefractometers also give this. And it can be between 10.5 to 13.5. We don't implant ICL or these lenses if the white to white is less than 10.5 millimeter. And it is recommended that automated measurements by one instrument and manual verification with caliper should be done for appropriate sizing. Or we can, it is estimated that the ICL size should be 1.1 millimeter higher than the white to white from AC depth in less than 3.5 millimeter, and when it is more than 3.5 millimeter, the ICL size should be 1.6 millimeter more than the white to white which we have measured. So how to measure it? It should be done under the microscope in high resolution in the supine position from middle of the limbus to middle of the limbus on the other side in a horizontal meridian, and we pre-treat the eye with anesthetic drop and calibrate the caliper always before we start the measuring. And this is how we get on a digital caliper the measurement. This can be used in all my cases. I think all of us, we use digital caliper, and it's better to use it yourself, to measure it yourself, but later on you can ask your technician or junior doctor or resident to measure it. Coming to the sulcus to sulcus measurement of white to white, there are various studies which say that there is no correlation between it, but some correlation has been postulated by some studies. But I think we should, and then it requires UBM to measure the sulcus to sulcus. Why this is important measurement of horizontal white to white? Because of the vaulting. So ICL provides a vault, and accurate preoperative white to white is very, very important. And what vault I have said earlier, I discussed earlier, this is the distance between the posterior surface of these two orange arrows will tell us the posterior surface of ICL and the anterior surface of the crystalline lens. This is the vault, and on the left side you see it's an adequate vault, and on the right side you see there is a low vault over there. So what will happen if the vault is not adequate? The adequate vault is 0.25 to 0.75 millimeter, which is half the corneal thickness. If we assume our corneal thickness of 500 micron, so our vault is also, if it is equal to the corneal thickness, then the vault is around 500 micron. So it should not be less than 250 micron, and it should not be more than 750 micron. So that is half of the corneal thickness or 1.5 of the corneal thickness, which is the higher side. And this can be easily compared on a slit lamp when we see the patient post-operatively. And an undersized vault, as you see, will induce anterior subcapsular cataract formation, and an oversized ICL or and a high vault will induce the rise in intraocular pressure and development of the glaucoma, and the iris will be pushed further. Last thing which has to be measured is the pupillometry, and the ASOCT should also be done in all these cases, because pupillometry, I know some cases has been recorded where the pupil size was not measured and they went into the litigation. So size of pupil should be measured, which is easily possible in all our OCT and in IOL Master. And anterior segment OCT is also equally important because it gives us the crystalline lens rise and angle to angle diameter. Recently, it is said that the angle to angle diameter is better and more comparable for the for the sulcus placement of the lens than the white to white measurement. Ultrasound UBM is done to measure the sulcus to sulcus. Now, this kind of a sheet comes to us when we send them the data to the company, and in the data, what we have to send them is the refraction, preoperative refraction, then with this cylinder and its axis, keratometry, anterior chamber depth, which is internal, corneal thickness, white to white measurement. These are the prerequisites which has to be sent to the company, and then they come and send us to their data, the type of lens which we are going to implant, and what will be the residual refractive error. As you can see in this particular, the preoperative refraction was 11.5 with 1.5 diopters of cylinder at 10 degree, and the size of ICL is 12.1 because our white to white was 10.7, and the lens is now 14.5 with plus 1.5 diopters of cylindrical correction and the residual expected refractive error on the right side. So these are other cases. In this particular case, we did it in 3.75 diopters of myopia because the corneal thickness was less. Another high myope case, and this is the other cases. Please move the slide, I think. It's not showing here. Is it moving? Yeah, now it is coming. So this is a similar thing is the sheet comes with the IPCL. We have to send them the same data, and then we get back the power and we look into it, because many a times there is a fallacy what we are sending to them and what they get back to us. And we have to look at the size of the ICL also in all these cases and what was our white to white. Complications, I think Dr. Mahipal will be discussing about the complications, but they are very less, and not in a very less number of patients we get the complication. This I wanted to share with you. This study came in 2021 with the centraflow design. Pre-centraflow era, the ICL results were different, and post-centraflow era, the ICL results have become much better, and the chances of development of cataract have decreased, and the patient's comfort is much higher. And you see, this is an 8-year study post central port moderate to high emmetropia cases, and the vision in 8 years, these are colorful bars are of 8 years, and whatever the post-surgery cases, which was at the end of first year, is same at the end of 7 years. Their height is almost same. So there is no change in refraction. There is no change in the vision after this. So to conclude, phakic IOLs are a safe and an effective tool for the surgical management. There is no blood, no pain, no hospitalization. It's cosmetically much acceptable and very good. Correction of wide range of myopia, hypermetropia, and astigmatism is possible now. The procedure is reversible, unlike LASIK. And just like LASIK and wavefront LASIK, procedure takes 5 to 10 minutes. The quality of vision is usually very good, and it creates a small corneal incision, so induced astigmatism is minimal, and we do not damage the incision, so chances of induced astigmatism is also less. Corneal tissue is not removed. Reduction of risk of optical distortion on or induction of higher order aberration is not there. Less glare issues in patients with large pupil, and also less risk of halos or double vision. Preserves accommodation and contrast sensitivity. Very stable over time, and there is no regression. If our preoperative workup, sir, please come on dais. If our preoperative workup is very good, a preoperative planning is very, very important in deciding the outcome of phakic IOL. I think if you give more time for the preoperative planning, then your postoperative results are predictable, and you don't have to give much time pre or postoperatively. Sizing related dilemmas are the primary concern of phakic IOL, and with the improvements in material and design, the rate of complications have significantly reduced. The possibility of complications and the benefits have to be weighed in each case individually, and patients should be informed about the options available before finalizing. I thank you for your patient hearing.
I think that was an excellent introduction and overview. I strongly believe the pre-surgical evaluation is as important as the process of surgery. Once you get used to the doing phakic intraocular lenses, it becomes fairly straightforward and simple. I think it was a very good coverage. Any questions for Dr. Bhasin? Yeah, please. May I request you to use the mic?
The mic, please.
For those cases where the ACD is extremely borderline, like you may get 2.7778. So you're in a dilemma because the patient is not a candidate for LASIK. So can you do some adjustment in your ICL parameters and or do a PI, although we are not doing PI these days? Is there any way to circumvent this?
No, I think it's a very pertinent question which you have raised. But if you are using it and you have an experience of doing phakic IOL, you can do it up to 2.75 or so. But I have not done in less than that. And then you have to change the size of the lens with the Indian lenses, because the ICL doesn't come with that less than 12.1 millimeter size of the lens. So I will say that it's better because you have to look at the lens rise also. And you have to see whether the angle of the anterior chamber, what kind of angle of anterior chamber is patient is having. So all these things are important. It's complete slit lamp examination and your experience of doing phakic lenses, because when the size is when the white to white is smaller, the surgical technique is also challenging when we do the case in, and it's better not to do it, and we will not recommend doing beyond 2.8 millimeter. And for the beginners, it is absolute new.
Do you do a PI in such cases then?
No, I don't.
I sort of echo what Dr. Bhasin said, in the sense, the only time I come to some kind of a pain with these cases is when we are compromised on ACD. And this question comes up often, in the sense that the cornea is not good for a refractive surgery. Patient is very keen and you have a borderline ACD. I stretch it up to 2.75. Less than that, I think it's better to stay away. Maybe some of these patients will get by, but then it's a risk you are taking. And PA has absolutely no role, though it's done for the psychological satisfaction of the patient, of the physician. Once you have a center of flow, there's already a communication between the posterior chamber and the anterior. So I would stick to 2.75 as was, but I would double check with another instrument. Sometimes you get on a pentacam, you get a measurement, then I do it on IOL master. IOL master is inaccurate as far as the white to white is concerned, but as far as the anterior chamber depth is concerned, it's a reasonably accurate measure. The other important factor would be, as already mentioned, whether the angles are open. If supposing it's 30 degrees and beyond a deep chamber, then wide angle open with just a 2.75 will go ahead. But if there is narrowing of the angle also, better to stay away.
Thank you.
Yeah. Can you switch on the mic?
Yeah, I have a question.
Yeah, please.
I've been doing all kinds of surgeries, but of late I've found that this phakic IOLs are a good option and a good way out of sacrificing tissues.
Please come on, dice.
From irreversible to reversible. Though hopefully reversibility of this doesn't sound good because patient has to get under the microscope once again. It's a wonderful thing, but what is one investigation which you recommend, which measures, gives you good white to white or sulcus, as well as the AC depth, as well as the angles? Which one investigation should my patient go to instead of going for UBM, pentacam? So can we have one or just bare minimum investigations which can give us a good...
I think it is what we, in all refractive procedures, we see that there should not be, because these are young patients and they want good vision post-operatively. So we should not go for any shortcut, what I feel is. But UBM is not required, definitely. But at least a couple of things are required. One is the IOL master, and one is the topography, tomography, and then the manual measurement of white to white. These are the three, sir, what you will, these are the three basic investigation which should be done in all these cases. If you have ASOCT, you should do it. If you have, but I don't do UBM in all my cases unless until like what Dr. Hazard was discussing in such cases. Otherwise, I don't do. But these three are mandatory.
So what is the gestation period of procuring these ICL vis-a-vis IPCL? How much time does it take to place an order and get these lenses?
Nowadays, I think it doesn't take much time. 3 to 5 days you get it. But IPCL may take some more time. But if it is toric, non-toric you get early.
Thank you very much.
One question.
Yes.
Often we find patients who have been implanted bilateral IOLs and still they have a lot of residual refractive error. So it is very difficult to find companies dealing with piggyback IOLs. So in that scenario, like, can we go for ICLs to correct the residual refractive error?
I think we have a talk on this, which will be dealt. I think Dr. Ramurthy is going to tell about it. But definitely, it can be used, and but it is expensive.
You're talking about residual error after a cataract surgery?
Yes, sir. Yes, sir.
You know, nowadays you have very good Sulcoflex lenses, and lenses are also available from the Indian manufacturers. So those lenses would be much more appropriate because they are made to, they are 14 millimeter overall diameter, 6.5 millimeter optic. So this was when we had only the Reina, it was very expensive. Now we have Indian options which can easily be placed. The placement of a phakic intraocular lens in front of a intraocular lens for correction of the residual error is an off-label use, and it's really not meant to be placed there. And again, the rotational stability cannot be assured.
So I think we will go further with